Imagine you're watching a horse, maybe after a bit of exercise or, even just standing quietly in their stall. And you notice something's a bit off with their breathing, not just a big sigh, but a real visible struggle to push the air out. Their flanks are heaving, maybe nostrils flaring a bit. It looks like an active, prolonged effort. That specific struggle, that kind of forced exhalation, it's more than just something you notice passingly. It's actually a critical clinical sign. A red flag, really. So today we're going to dive deep into exactly that, equine expiratory dyspnea. And it's not just a fancy term, it's the main clinical sign that points towards some pretty serious lower airway conditions, basically where the horse faces increased resistance trying to get air out of its lungs.
Right. And our mission here, drawing from the specialist study guide and the overview paper you mentioned, is really to pull out the most important, actionable insights. So by the end of this, you should have a really solid understanding of what's actually happening inside that horse when it struggles to breathe out. We'll focus particularly on that common culprit people often just call heaves.
Exactly. So whether you own horses, manage a barn, or maybe you're just fascinated by animal health, think of this as your shortcut to getting properly informed on this specific challenge. We'll try to blend the essential facts with maybe some surprising details and always link it back to why this stuff actually matters to you and the horses you might care for. Okay, so let's unpack this struggle a bit. When we talk about expiratory dyspnea, what does that really mean? It's labored, difficult breathing. But the key, like we said, is the exhalation part. It becomes active, it takes longer. You physically see the horse straining, working hard to push air out. And yeah, like you said, in the horse world, lots of people just call this heaves.
And to really get why that's such a problem, it helps to think about normal breathing first. Normally, when a horse is just resting, breathing out is mostly passive. Think of it like letting the air out of a balloon. It happens because the lungs in the chest wall are elastic. They just naturally recoil. The diaphragm relaxes, the ribs settle back, and air just flows out. No real effort needed. Now, contrast that with what goes wrong in obstructive airway disease, which is where this expiratory dyspnea really shows up. The whole mechanics change. First, you get airway narrowing. This can be from bronchospasm. That's where the little muscles around the small airways, the bronchioles, tighten up.
Like a cramp in the airways?
Exactly like that. Plus, you often get mucus building up, and the airway walls themselves get thicker from edema that's swelling or inflammation, maybe even fibrosis, which is like scarring over time. All of that just shrinks the space inside those tiny airways.
Okay, so the pipes are getting narrower.
Right. And then, second, when the horse tries to breathe out forcefully, those already narrow airways get squeezed even more. This traps air down in the little air sacs, the alveoli. We call that air trapping or hyperinflation. The lungs stay too full.
Okay, so they can't fully empty.
Precisely.
Right.
And because the air is trapped and the passages are narrow, the horse has to switch to active exhalation. They have to start using powerful abdominal muscles, the internal intercostals, and especially the external abdominal obliques to literally force the air out against that resistance.
Wow. So it's not just a muscle straining, it's actually getting bigger from all that constant work. That must be a really clear visual sign.
It is. It's profound. That sustained, forced effort leads to that very characteristic sign, the heave line. That line you can sometimes see along the horse's flank. That's the external abdominal oblique muscle becoming hypertrophied, just enlarged from overuse.
Right.
It's a stark indicator of the sheer effort involved. And all this increased work of breathing, well, it leads to fatigue, poor oxygen exchange. It impacts everything.
Okay, so here's where it gets really interesting. Because that specific struggle, that heave line, it usually points towards one main suspect, doesn't it? Recurrent airway obstruction, or RAO. That's the big one.
That is absolutely the most common and clinically significant cause of the kind of expiratory dyspnea we're describing. Yes, RAO. You might have heard older terms like heaves or even COPD in horses, though we tend not to use COPD anymore. It's a common, often debilitating, non-infectious, inflammatory disease of the lower airways. It mainly affects mature horses.
And what actually causes it? Is it like an allergy?
Essentially, yes. It's primarily a hypersensitivity reaction. Think of it like the horse's immune system just going way overboard, reacting to things in the environment that should be harmless. Specifically, inhaled organic dusts, molds, and something called endotoxins. The sources point to common triggers like Micropolis spirifani and Aspergillus fumigatus. Those are specific molds, other fungal spores, dust mites. Things commonly found in hay and straw, unfortunately.
And what's really fascinating, I think, is that it can show up differently depending on the season or environment, right? These variants.
That's right. The most common form is what we call barn-associated RAO. Here, the signs get worse when the horse is stabled, eating hay, bedded on straw. put them out on pasture, and often they get much better.
Okay, that makes sense with the triggers.
Then there's the less common one, pasture-associated RAO, sometimes called SPAOPD, summer pasture-associated obstructive pulmonary disease. Here, it's flipped. The signs actually get worse on pasture, usually in warm, humid climates. The triggers are different, maybe certain pollens or molds found in grasses during those warmer months.
So their environment can literally be the problem,
Yeah.
depending on the type.
Exactly. Now, the clinical picture of RAO, it's often quite distinct, and it tends to get worse over time if not managed. Typically, you see it in mature horses, say over 7 years old. Some breeds seem more prone, quarter horses, thoroughbreds, warm bloods, ponies sometimes.
And what are owners usually complaining about?
The main things are a chronic cough, often sounds moist or hacking, definitely exercise intolerance, they just can't perform like they used to, and that progressive expiratory dyspnea we've been talking about. During an acute flare-up, what people call a Heaves attack, it gets much worse. Obvious difficulty breathing out even at rest, flared nostrils, they might look anxious.
That heave line would be very prominent then.
Very prominent, yes. Plus, an increased breathing rate to chypnea, often some nasal discharge, maybe thick, maybe white or yellowish from both nostrils, and if a vet listens to the lungs,
Wheezes, crackles.
definitely audible wheezes and crackles, especially on exhalation. And if it becomes chronic, without good management, you can see weight loss.
Why the weight loss? Just the effort.
Partly the huge energy cost of breathing, yes. But also, sometimes they have trouble eating comfortably when they're struggling to breathe. They can get quite thin, cachexic, with those heave lines really standing out, a tucked-up abdomen. And episodes just tend to get more frequent and more severe if the environment isn't fixed.
Okay, so RAO is clearly the main story here. But it does raise a critical question, both for vets and for you as an owner. How do you know it is RAO and not something else? Because other things could cause similar signs, right?
Yeah.
Understanding that seems vital for getting the right treatment.
Oh, absolutely vital. While RAO is the most likely candidate in many cases, the sources are clear. You have to consider other possibilities. Differential diagnoses are crucial. Things like inflammatory airway disease or IAD, which often affects younger horses, aspiration pneumonia, where something's gone down the wrong pipe, chronic bronchitis or bronchiolitis, fungal pneumonia, even tumors neoplasia or granulomatous lung disease. And sometimes even left-sided heart failure can cause respiratory signs.
So how do you tell them apart? Are there key clues?
There are. For instance, fever is a big one. It's really unusual in straightforward RAO, but very common with infections like bacterial pneumonia. The age of the horse is often a clue, as I mentioned. RAO is typically mature horses, IAD often younger performance horses. And the onset, RAO usually creeps up gradually, whereas something like pneumonia might come on much more suddenly. So the guidelines suggest that if you've ruled out an obvious blockage in the upper airway and you have a mature horse with no fever showing that gradual onset expiratory dyspnea, especially if there's a link to dusty environments, RAO jumps way up the list of possibilities.
Got it. So let's walk through that diagnostic process. It sounds like detective work. It starts with the history, right?
Mhm.
Why is getting all that background detail so critical? You mentioned the vet asking about stabling, hay, pasture.
It's paramount because RAO is so linked to environmental triggers that history is your first and maybe most important diagnostic tool. You need to know, where does the horse live? What's the bedding? What kind of hay? Is it soaked? Are they getting pellets? Are they out on pasture? When did the signs start? How long have they been going on? What treatments have been tried? All those details help build the case for or against RAO.
Okay, history first, then the hands-on exam.
Exactly, the clinical examination. Just observing the horse at rest. Noting the respiratory rate, the pattern, are the nostrils flaring? Is there obvious abdominal effort? Can you see that heave line? Sometimes you even see the anus bulging slightly in time with breathing because of the high pressure inside the abdomen. And their posture, sometimes they stand with their elbows slightly out. And then, of course, listening carefully to the lungs with a stethoscope auscultation for those characteristic wheezes and crackles, which are usually loudest when they breathe out.
And you mentioned something called a rebreathing exam. Putting a bag over their nose, that sounds a bit intense.
It does, but it's a really useful diagnostic test. You place a large plastic bag over the horse's nose for, say, 1 to 2 minutes. What this does is safely increase the carbon dioxide they rebreathe, which stimulates them to take deeper, more forceful breaths for a short time afterward. In a horse with RAO, this often makes the abnormal lung sounds, the wheezes and crackles, much easier to hear, and it can also make that expiratory effort more obvious. It helps unmask the problem if it's subtle at rest.
Right, it kind of provokes the signs. What about looking inside? Endoscopy.
Yes, endoscopic examination or tracheobronchoscopy. We pass a flexible scope with a camera down the horse's airway. This lets us actually see the inside of the trachea and the main bronchi. We're looking for things like excess mucus, how much, what does it look like, signs of inflammation, redness, swelling, and sometimes you can even see if the larger airways are tending to collapse dynamically during exhalation.
Okay. And then the real definitive test. You mentioned airway sampling.
That's right. Airway sampling, specifically something called bronchoalveolar lavage, or BAL, is generally considered the gold standard for diagnosing lower airway disease like RAO.
How does that work?
Essentially, the scope is passed down as far as possible into a small airway, a small amount of sterile saline is flushed in, and then immediately suctioned back out. This collects cells and fluid from the deep parts of the lungs, the alveoli, and small airways.
What are you looking for in that sample?
The key thing for RAO diagnosis is the cytology, looking at the types of cells present. In RAO, we typically see marked neutrophilic inflammation. That means a high percentage of neutrophils, a type of white blood cell. Usually over 20–25% in a BO sample is highly suggestive of RAO in the right clinical context.
So finding those neutrophils is really the clincher.
It's a very strong indicator, yes. It confirms that inflammatory process is happening down low, and it helps differentiate RAO from other conditions like IAD, which might have more mixed inflammation, or normal lungs, which have very few neutrophils. We can also use the BL fluid for culture if we suspect a bacterial infection might be complicating things, but usually in RAO, it's primarily inflammation, not infection.
Are there other tests, like x-rays?
Thoracic radiography, or chest x-rays, can be done, but they're often not that helpful for diagnosing early or mild RAO. The changes can be quite subtle. They're more useful if you suspect something else, like pneumonia, or if the RAO is very severe and chronic, you might see some changes like bronchial wall thickening. There's also pulmonary function testing, but that's more specialized, often used in research settings, and allergen testing. Well, its role in directly diagnosing RAO is still a bit controversial. It doesn't always correlate well with clinical signs.
Okay, so we've got the diagnosis. Now, what does this actually mean for managing a horse with RAO? You mentioned two main pillars.
That's right. It boils down to two crucial things: environmental modification and pharmacological intervention. And let me be absolutely clear, the single most critical part, the foundation of everything, is environmental management. Our sources literally say no amount of drugs will compensate for a poor environment. I really can't stress that enough.
So step one is always clean up the environment.
Always. You have to eliminate or drastically reduce exposure to those dusts and molds. That's the core of the problem. So, concrete strategies. Pasture turnout is often called the ideal management. If it works for the horse and it's not pasture-associated RAO, living outside 24/7 is fantastic.
But that's not always practical.
No, it isn't. So hay alternatives become key. Soaking hay, completely submerging it for maybe 30 minutes to an hour, can dramatically reduce the breathable dust and mold spores.
Does soaking take out nutrients, though?
It can leach some soluble nutrients, yes. Steamed hay, using a commercial hay steamer, is actually more effective at killing molds and mites and reduces nutrient loss compared to soaking. It's a better option if feasible. Other options are haylage or silage, if properly made and stored, or switching entirely to complete pelleted or cubed feeds, which are generally very low dust.
Okay, so feed is huge. What about bedding? Straw seems like a bad idea.
Definitely. Straw is often very dusty and moldy. You want to switch to low-dust options like wood shavings, cardboard, paper bedding, or even just rubber mats with minimal bedding. Ventilation in the stable is also vital. You need good air exchange to prevent dust buildup. And basic cleanliness practices: clean stalls daily, sweep aisles when the horse is not in the barn, don't store hay overhead where dust can filter down.
And for the pasture-associated type, you do the opposite.
Exactly. For pasture-associated RAO, you need to limit pasture exposure during the problem season. Move them to a dry lot or a very well-ventilated stable. Provide that low-dust feed and bedding. Maybe even consider air filtration systems in the stall in some severe cases.
Wow, that's a lot on the environmental front. It sounds like it requires real dedication from the owner. What if someone just can't do all of that? Is there any point just using medication?
That's a tough but realistic question. The reality is, medication works so much better when the environmental triggers are reduced. If you only use drugs without changing the environment, you're constantly fighting an uphill battle. The inflammation keeps getting re-triggered. So The goal should always be to do as much environmental modification as is realistically possible. Even partial changes are better than none. Maybe you can't do 24/7 turnout, but you can switch to steamed hay and shavings. That still helps significantly.
Okay, so environment first, optimize that as much as possible, then the meds come in.
Precisely. Pharmacological treatment is there to control the symptoms, the bronchospasm, and the inflammation, but it really should only come after or alongside those environmental changes.
So what kind of medications are we talking about?
Two main categories. First, bronchodilators. Their job is to relax those tightened airway muscles, open things up, and provide relatively quick relief from the breathing difficulty. You can give them systemically, like oral clenbuterol syrup, or often preferred are inhaled options.
Like human asthma inhalers.
Similar principle, yes. Medications like albuterol, or salbutamol as it's also known, and ipratropium bromide can be given using a special equine inhaler mask. The advantage of inhaled is rapid action right where it's needed in the lungs, with fewer potential side effects elsewhere in the body.
Okay, so bronchodilators for immediate relief.
What about the underlying inflammation?
That's where corticosteroids come in. They are absolutely the cornerstone of medical management because they target the inflammation that's driving the whole disease process. Again, you have systemic options like injectable or oral dexamethasone, very potent, very effective for severe flare-ups.
But steroids have side effects, right? Laminitis risk?
Exactly. There are risks, especially with long-term or high-dose systemic use. Laminitis is the big concern, plus potential immune suppression. So they're used carefully, lowest effective dose, shortest possible time for acute crises. For long-term management, inhaled corticosteroids are generally much preferred. Things like fluticasone propionate, given via an MDI puffered with a mask, or budesonide, which can be nebulized.
Why are inhaled steroids better? Because they deliver the anti-inflammatory medication directly to the lungs where it's needed with very minimal absorption into the rest of the body. This drastically reduces the risk of those systemic side effects like laminitis. They are ideal for chronic control.
Are there other supportive treatments?
Yes, sometimes adjunctive therapies can help. Mucolytics, like bromhexine orally or nebulizing saline or acetylcysteine, might help thin out thick mucus, making it easier to clear. Good hydration is always important too, and a really important point. Antimicrobials or antibiotics are generally not needed or helpful for RAO itself because it's an inflammatory condition, not an infection.
Unless there's proof infection.
Exactly. Only if a secondary bacterial infection is confirmed, say from that BAL culture, would antibiotics be indicated. Otherwise, they're pointless and contribute to resistance issues. Some people also use omega-3 fatty acid supplements as they might have some mild anti-inflammatory effects, but the evidence is still developing there.
And just to clarify, a tracheotomy surgery, that's not for RAO.
Correct. A tracheotomy creates an opening in the windpipe in the neck. That's a procedure used for fixed upper airway obstructions, like something blocking the larynx. It doesn't help with lower airway disease like RAO, where the problem is deep inside the lungs.
Okay, so connecting all this back to the bigger picture.
Yeah.
If a horse gets diagnosed with RAO, what's the realistic long-term outlook? What should you, as the owner, expect?
Well, the prognosis is generally described as fair to good for management. It's crucial to understand, as we said, RAO is chronic, it's progressive if not managed, and there is currently no cure. The underlying hypersensitivity doesn't go away.
But it can be managed.
Yes, absolutely. The good news is that with strict, consistent environmental control and the right medication plan, most horses can be managed effectively. They can often maintain a good quality of life. However, their ability to perform athletically is often limited, especially for demanding sports requiring high aerobic fitness. And sadly, horses with very severe chronic changes may not be able to return to work at all.
How do you keep track of how things are going?
Monitoring is key. It involves regular checks of their clinical signs, breathing rate, effort, cough, nasal discharge, both by the owner and the vet. Periodic rebreathing exams can be helpful. And sometimes, follow-up endoscopy or even repeat BAL sampling might be needed to see if the inflammation is under control and adjust the treatment plan accordingly.
Right. So let's quickly recap the core takeaways from this deep dive then. Expiratory dyspnea, that visible struggle to breathe out strongly, points to lower airway obstruction. And recurrent airway obstruction, RAO, is the #1 cause in mature horses and the absolute key to controlling it. Rigorous environmental management.
Absolutely. And diagnostically, that BAL cytology showing neutrophils is the gold standard. While bronchodilators give that needed quick relief in a flare-up, it's really the inhaled corticosteroids that are crucial for managing the underlying inflammation long-term and hopefully preventing permanent lung damage.
So here's a final thought for you to take away. Given that catching this early and managing it aggressively can genuinely prevent irreversible lung damage and preserve a horse's quality of life, what steps might you consider if you notice even subtle changes in a horse's breathing? Especially knowing now just how critical paying attention to their environment truly is. It really encourages you to be observant, to be informed, and to be an advocate for their respiratory health. Sometimes those quiet struggles really do need the most attention.